Thank you for joining today. I have the extreme honor to introduce our Charles James. He's the president and CEO of North Indiana Healthcare Management Services. And Charles, thank you for joining us today.
Thank you very much. So, hey, we're all here. Little technical difficulties, but adapt and overcome, right? I think that's the Marine Corps motto, even though I wasn't a Marine. So, at any rate, thank you very much for being present today. Thank you to Dana and Autumn and Tina Elliott and IHCP for coordinating this. I think that many of us have webinar fatigue. In researching this, I was listening to some of the initial phone calls and webinar recordings that were happening in March, and wow, what a crazy time that was. I think the biggest question we all have right now is, where is this going? How long is this going to last? Can we still build telehealth? And how long are we going to be able to do that for? So those are some of the questions we're going to try to answer today. And I realized as I just started this presentation, although I didn't put my objectives on here. So you have the objectives on the meeting description. So we'll go from there. So what we're going to do today is really talk about a telehealth update, where we stand, what we can do, how long we can do that as a rural health clinic in FQHC, as well as care management services. When Dana and I first started talking about this, the question was from Dana. She has a lot of folks asking where care management services fit into telehealth for us, and we're going to explore that a little bit. So let's review. Even though for most of us, these events started in March, we actually had a public health emergency declaration by Secretary Azar, federal HHS secretary. That public health emergency was dated January 31st, but according to this, said this has existed since January 27. So as we go through and we read a lot of the emergency declarations and we see this January 27 date, it's from right here. So the public health emergency was declared. Of course, it wasn't until mid-March that we started to get all of these lockdown orders, but public health emergency, January 27, 2020. Most of the telehealth provisions that we have grown accustomed to only last as long as the public health emergency. In addition to the federal public health emergency, of course, every state has their own public health emergency. At the state level, that helps us enable resources, and a lot of legal things happen after a public health emergency is declared. I didn't go in at all into any of the location waivers, et cetera, but those location waivers are all also contingent on the public health emergency. And in addition to those state level public health emergencies, we have kind of varying levers that are in motion here. So federal public health emergency, January 27. This is a totally mashed up version of the certificate. So I put my Microsoft Paint skills to use. So that is not an accurate reflection. There are another page and a half of whereas in the actual Indiana public health emergency. The Indiana public health emergency was declared on March 6th by Executive Order 2002. And I just want to say that adjacent image is an abbreviated version of the actual public health emergency. And if you want to go into all of the executive orders and statutory waivers, we'll have this slide deck available. You can look at those at that link right there, designated by here. So March 6, 2020 is the Indiana public health emergency. That gets updated every 30 days. So when you go and you look at this list of statutory waivers, you go look and you say, updated, 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 another declaration, another extension of 30 days. So right now we're acting under a series of 30-day extensions to the public health emergency. None of us know when the public health emergency will end. A lot of us at the state level are getting nervous because we're not seeing extensions. For example, down in Texas, we had some heartburn because we still don't have a extension to the public health emergency. But in effect, I've seen no formal ending of any emergency public health, any termination of any public health emergency at the state or the federal level. And I think we can expect this to go on through 2020. So for right now, everything is still in place and there is no finite date when any of our telehealth services or location waivers will end. We are still under the public health emergency for the foreseeable future. Now, part of our conversation is what's going to happen after the public health emergency and how long will our telehealth services will we be able to bill for these? As I just said, to the public health emergency, if the public health emergency ended today, everything tomorrow would go back to the way things were with really no telehealth benefit other than originating site. Senate Bill 3998 is currently on the floor in the Senate, or if that's the right word. Angus King of Maine and Cindy Hyde-Smith from Mississippi introduced Senate Bill 3998. We're going to see in a second, we're going to talk about the clawback that's going to happen with our telehealth services being paid at the AR and then reconciled to $92.03. Senate Bill 3998 removes that clawback provision. It doesn't make telehealth permanent, but it removes the clawback provision. The reason I go into this is because this is the only legislation that's out there right now to make our changes permanent. On the House side, we have House Resolution 6792. House Resolution 6792 also addresses the quote unquote clawback, but it also would make permanent our serving as a distant site and that we can be paid our all-inclusive rate for telehealth services going forward. Both of these are still in the writing phase. There's a Senate bill, there's a House bill. We don't have any reconciled bill between the two. And what I would suggest to you all, anybody listening, I make a lot of calls, a lot of contacts to promote these bills. I'm a mercenary. People don't care about me. 25 of my calls don't equal one call from an actual rural health clinic provider. So please have your folks contact your U.S. representatives, U.S. senators, and please ask them to co-sponsor in the House HR 6792 and in the Senate 3998. We desperately need these bills going forward. There is great reluctance at CMS and in the Senate to make changes permanent. That will gain momentum if they start hearing from rural health clinics and FQHCs. So these two bills seek to make these changes permanent as distant site for RHC, FQHC, paid at the AR, and eliminate the clawback. So that's kind of where we stand at the federal level right now. At the state level, IHCP, Indiana Health Coverage Programs, has eliminated the extended timely filing limit. So BT 202072, effective June 11th, adjusts timely filing limits for our MCOs back to 90 days. So at the beginning of the public health emergency, one of the waivers that we got was 180-day timely filing. After July 15, our MCO timely filing goes back to 90 days. So that's really important. You know, if you don't get a claim on your MCO, you don't get anything. No rural health, no FQHC, reconciliation. So this 90-day timely filing limit is very consequential. That's going back to 90 days, July 15. There is an updated telehealth FAQ BT 202071, again, June 11, 2020, states that all of the policies that we've got are in effect until the end of the national public health emergency. It didn't do any good for me to go through all of the FAQ provisions on here, but I encourage everybody listening to please follow the link right there. Anything highlighted and underscored is a link. Follow it to the FAQ, and there's a lot of really good granular information in there about OB services, about prior authorizations, etc. One of the big things that telehealth waivers brought to us were waiving the prior authorization requirements. So please explore this FAQ for in-depth information on all these. I just didn't have time to go into all of that level of detail. But please go see this updated FAQ, updated June 11, 2020. The initial telehealth bulletin that waived everything for Indiana healthcare providers was BT 202022. That was our COVID-19 telehealth bulletin, and it started to waive all of the provisions for COVID-19, even though telehealth as an encounter was already cooked into some of our rural health clinic policies, FQHC policies. This bulletin formalized those, and we're going to look at the components of those. So first of all services delivered through telemedicine are subject to the same limitations and restrictions as if they were rendered in person. That's big number one. Consent from the member has to be obtained by the provider prior to delivering services. And we have to maintain documentation to substantiate that the services were provided, and consent was obtained. This is really important. I was just on a call with Kate Hill from compliance team, and we were talking about the importance that is going to the urgency of appropriate documentation for our telemedicine visits going forward is something that's going to start getting looked at in surveys. So it's very important that we're documenting our telehealth services appropriately, that we're documenting that we obtain consent appropriately, and that we rendered services via telehealth. And for IHCP, look at the fourth bullet. Clearly identify the location of the provider and the patient, and that information must be available for post-payment review. And importantly, the provider and or the patient can be located in their home while these services are provided, but we have to document the location of the patient and the provider. We can use any technology that allows for real-time interactive consultation between the patient and the provider. This includes computers, phones. I've got part of my screen blocked out here, so let me minimize that a little bit. There we go. Or television monitors. We can use voice only, so telephone only works, but non-voice communications such as emails and text messages do not constitute a telehealth visit under Indiana health coverage programs. It's really important to, let's see, the voice only, non-voice communication. I totally lost my point, so I'll come back to it. This is from the 2020 bulletin. It said, if we are going to use telemedicine services, we should refer to the telemedicine and telehealth service provider reference in the IHCP provider modules, excuse me. This says RHCs and FQHCs, we can bill for telemedicine visits as long as what we're providing is a valid RHC or FQHC encounter. Got to follow established guidance for current telemedicine policy, or use modifier GT if it's not on our encounter list. That's a little bit misstated there, so we'll get to that a little more in depth. We can be reimbursed as either the distant site or the originating site for telemedicine services. In RHC or FQHC, We can be the distant site or the originating site. And again, remember, the distant site is where the provider is. The originating site is where the patient is. At the Medicare level, the telehealth statute required the patient to be in a healthcare facility. So the actual law creating telehealth prevented patients from being in their home for a telehealth visit. They had to be in a medical facility. Critical access hospital, FQHC, RHC, there were some other venues, but that is all waived during the public health emergency. That's why we had to wait for so long, because Congress had to enact a law that waived that statutory provision. But Indiana, we can serve as either or. Now, look at this. When we're the distant site, this is really important. The service provided by the RHC or FQHC must meet the requirements for a valid encounter and for an approved telemedicine service. The encounter code T1015 gets billed with our regular place of service. So if we're a health clinic, we're 72. For FQHC, we're a 50. I'm not going to go into the other ones. We're talking about RHCs and FQHCs. So we're going to enter our normal place of service. It's on the CPT code that we enter a modifier 95 and a place of service 2. We don't use a GT modifier for anything that's on the encounter list. The T1015 gets billed out as our normal place of service code, and it's the CPT detail that gets the modifier 95 and a place of service code 2. That's distant site. If we're an originating site, it's largely the same thing. We have a T1015 with our regular place of service, but the Q3014 gets billed with the place of service 2 and modifier 95. So we have different place of service codes going out on the different detail line items, depending if it's a T1015 or if it's our HCPC code. So be particularly careful with that. This created me a great deal of confusion. During our public health emergency, our telemedicine services are not limited to the codes on the telemedicine code set. If you bill a code not listed on that code set, that's when we use the modifier GT. Only for codes not on the code set. So this would be an extenuating circumstance. Codes that are not on the code set, for example, there's some surgeries, there's some therapies, etc. But again, our normal billing method for anything that is on our telemedicine code set gets billed place of service normal, CPT code with modifier 95 and place of service 02. So basically, ignore the GT modifier except in extenuating circumstances for Indiana Medicaid. Let's talk about Medicare. We know that effective March 27th, we got the CARES Act signed into law that allowed us to immediately be paid for distant site services as an RHC FQHC for the duration of the public health emergency. So that's when we were able to do that. Distant site providers, any provider in our RHC or FQHC, any healthcare practitioner appropriately licensed in the state can bill an RHC or FQHC telehealth visit. Any healthcare practitioner. So if we have an RN licensed in the state, LPN, MAs, if they're licensed in the state, they can furnish distant site telehealth services from any location, including in their home. So doctors working at home can provide a telehealth visit to a patient in their home for the duration of the public health emergency. This includes nursing visits. So this is strange. This is only for telehealth, This does not apply to in-person visits, but this is a unique situation where we could get RN services paid as a telehealth visit. 99211 paid as a telehealth visit. Now, I just saw where NGS came out and said diabetic nutrition, so diabetic counseling, is not billable via telehealth. I haven't seen that anywhere else other than an email that came to me. But generally speaking, again, any licensed healthcare practitioner can furnish distant site services during this public health emergency. Now, one thing that was very confusing for us too was at first we were being told before that March 27 CARES Act that telephone only could only be a virtual check-in service. With the CARES Act, that changed so that any telephone visit that is at least 5 minutes and the physician may report an E&M service, that can be done for a telephone only service. We get some of the same virtual check-in language, but in general, if we have greater than 5 minutes of telephone only, a G2025 telehealth visit can be billed as long as we have greater than 5 minutes of time on the phone. So if we have a timestamp like that, at least 5 minutes, we're going to document start and stop times in our note. So remember, documentation is going to become very important on these. If it's a time stamped service, which G2025 is, we have to document start and stop times. So please do that with our G2025. Notice our all-inclusive rate payments, that's the clawback. If we billed those prior to today, today's the cutoff date, Medicare is going to pay at the AIR for any G2025, and then after tomorrow, July 1, Medicare is going to reconcile those back to $92.03. Okay? So any telehealth services paid before today and paid at the AIR do not need to be resubmitted. Medicare is going to automatically adjust these, but they're going to be reconciled down to $92.03. So what does that mean? It means that if you're provider-based and your rate is more than, your all-inclusive rate is more than $92.03, Medicare is going to come back and take money back in the amount over $92 up to your rate amount. If you're an independent and you're capped at $86, Medicare is going to come back and they're going to pay you $6. So the clawback only happens for provider-based rural health clinics, really, or FQHCs whose PPS rate is greater than $92, who most FQHCs should be, and any provider-based rural health clinics whose uncapped rate is greater than $92. Medicare is going to come back and adjust those claims automatically. You don't need to resubmit those. After July 1st, G2025 will be our distant site service. We have to submit without the G202, excuse me, I'm misspeaking. After July 1, no CG modifier. Before July 1, we have to use the CG modifier. We have to get patient consent for all services, including non-face-to-face. So we have to get beneficiary consent even for our telehealth services. That can be done under general supervision. So it doesn't have to be done by the doc or the provider. It can be done by a staff person, but we do have to obtain patient consent. So here's our RHC service with the CG modifier required through June 30. These up until today will be paid at the all-inclusive rate. Modifier 95 may be reported, but it's not required. We're going to report modifier 95 on everything because that's going to help us track it. That's just in our own shop. So CG modifier up to June 30 is required. These will be paid at the all-inclusive rate. We can put all three of those modifiers on there. We're going to cover CS here in a second. I'm sure everybody's already seen that. Here are our RHC distance site services after July 1. We no longer have to report the CG modifier. These claims will be paid at the $92 and not going to be a clawback. For FQHC services, we have to, up until today, report our G code. We have to report our HCPC code that was rendered with the modifier 95. We have to report our G2025 with the modifier 95. These will be paid, I've said FQHC's all-inclusive rate at our PPS rate. We don't need to resubmit these. These will be reprocessed. That's what our FQHC code is going to look like. How about FQHC after July 1? Same thing. So FQHCs don't deal with the CG modifier. We don't have to report the payment code. CS is only for COVID-related services. Modifier 95 is optional. Claims will be paid at $92. So we put a $94 charge on it. Medicare will apply cost sharing to telehealth services, both RHC and FQHC. So let's go back. RHC after tomorrow, starting tomorrow, paid at the AIR. FQHC starting tomorrow. There will be coinsurance and deductible on these. That $92.03 is a composite rate. Medicare took the allowable for all telehealth services, and just like on our care management services we're going to see in a few minutes, we have this composite rate with this, which is the national average of the physician fee schedule amount. So if the public health emergency goes beyond 12/31, CMS is going to reprice our G2025 with 2021 physician fee schedule average amounts. We can perform annual wellness visits via telehealth. Medicare has come out and announced that as long as all of the elements of the AWV are provided, we can do this via telehealth. Now, the big issue is for the fee-for-service world, there doesn't have to be a physical exam, right? For the rural health clinic FQHC world, for annual wellness visit to be payable, there has to be a physical exam. So annual wellness visit, we can do it via telehealth, can be administered via audio-only technology if a video connection is not possible. Of course, what's the urgency to get our annual wellness visits? It's so that we can report our quality measures to our ACOs. Now, the issue is we're not going to be able to provide any claim-based quality reporting because we must submit a G2025 and we don't have any actual detail. So this presents some problems for our G2025. First of all, we're not submitting service detail, or Medicare is going to ignore it if we do. So the Medicare Coordination of Benefits is not going to capture our CPT details. So for example, they won't know that an annual wellness visit was performed. They won't know not to apply coinsurance or deductible amounts on an annual wellness visit via telehealth because they're not getting the CPT detail. They don't know deductible and coinsurance amounts because we're just applying this to a telehealth service. Our ACOs are not going to be able to get claim-based quality measures, or RHCs for that matter, because we're not submitting that data to Medicare. Or if a provider is compensated based on RVUs, how are they going to be reimbursed? Now look, this is a suggestion, okay? This is not a requirement. This may or may not work on your system, But a lot of us are feeling like we really need to capture the detail that happens in conjunction with our telehealth visit. So what we're doing is we're posting the actual detail. We're going to post a subsequent annual wellness visit. We're going to post it as a zero charge. We're going to suppress that from our claim. And of course, if we post additional E&M services, evaluation and management, or face-to-face visits, we have to remove those. We don't want to count those in our cost report calculations. It will very much throw our productivity calculations, but suppress these claims within your system, and then when you go back, you at least have something, you at least have some detail in the system. We think Medicare is likely going to have to come back and adjust this somehow because we're not capturing this data, and it's as important to Medicare that we capture this data as it is to us. So this circumvents part of that problem, but again, remember, this is a suggestion, not a requirement. We can only have G2025 go out on the claim, not the detail. We've got to remove those extra suppressed line items from the cost report, and they're only for reporting and tracking. So this is a suggested method, but it's working, and a lot of us are doing that. Our CS modifier for COVID-related services. Remember, CS is only for COVID-related services. So if we see a patient that results in a COVID test, including on telehealth, we're going to report the CS modifier. Prior to, again, CMS and our MACs had to implement all of these provisions incrementally and on the fly and on an emergency basis. So that's why we have this incremental approach. CG modifier today, no CG modifier tomorrow. FQHC payment codes, no payment codes tomorrow. A lot of us know that we see CS modifiers being reported. We're still getting coinsurance and deductible applied. Unfortunately, you're going to have a mechanism internally to know not to collect that from patients. We're getting a few of these in our billing shop where we've got CS modifier appended, but Medicare is applying a coinsurance on those. Just don't collect it. Medicare is going to come back and reprocess those claims beginning July 1, but it is going to be a bit messy. Medicare is going to pay 100% of the reasonable cost for any COVID-related service. So that means when they're paying 100% of the reasonable cost, that means there's no coinsurance or deductible amount, is what that means. Do not conflate our ability to just waive coinsurance at our own discretion with the CS modifier. We are required to waive COVID-related services with the CS modifier. We have to do that. At our own discretion, and a lot of us were doing this at the beginning of the public health emergency, just to say, hey, patients, we'll see you via telehealth. We won't have any coinsurance or deductible amount. We'll waive that. But it's much like our HIPAA waiver. HHS is not going to enforce the statutes that require us to collect all coinsurance and deductible amounts. These are kickback statutes, anti-kickback statutes, and OIG is not going to enforce those provisions. So we can, on our own, waive coinsurance at our own discretion, but we really need to do it the same for everybody. So the only reason I put this up there, a lot of us were conflating the CS modifier for COVID-related tests only with our ability to waive all coinsurance, and the two are not the same. Here's the difference. So I just wanted to highlight that. We are not using telehealth-related costs at this point in the cost report. These will all be removed from the cost report. We're going to report originating distance site telehealth costs on a particular line item, but those are not going to go in to support our rate for right now. If we get the House bill and the House resolution and the Senate bill I talked about passed, then if we get RHC, FQHC services at our all-inclusive rate or PPS rate, we would then expect all of our telehealth services to go into our cost report, just like they would normally be included in our productivity limits. So right now they're not. If we get the legislation change, we would assume that our telehealth visits will go into our productivity calculation. Telehealth services are not paid under the RHC AAR or FQHC PPS. So Medicare Advantage is not going to pay any wraparound payment. Any wraparound payment will be paid by the MA plan, which we know they're not going to pay a wraparound payment. So if you're not getting your all-inclusive rate or PPS rate from your Medicare Advantage plans, they're just going to pay you your fee-for-service rate, and there's not going to be any recourse for that. So as always, we would never put any Medicare Advantage costs on our cost report. We would never try to reconcile Medicare Advantage RHC claims on our cost report. In effect, our Medicare Advantage payers are commercial payers for us, but there is no formal wraparound with them. Now, one thing, the thought that escaped me a few minutes ago back was the distinction between telemedicine and telehealth. Indiana actually cooks this into some of your policies, and your telehealth versus telemedicine policy makes this distinction. Telehealth is the whole range of services that can be provided by any healthcare professional, like our LPNs, our MAs, our RNs, our diabetic counselors, anybody, on an electronic forum, not necessarily a telephone, but any store and forward, asynchronous, audio, video, telephone, email, text. These are all telehealth services. When our providers see patients via telehealth platform, then we're talking about telemedicine. So I usually just use the term interchangeably. When we're talking about telemedicine, though, our provider services are one component of telehealth services. Our virtual check-ins, our e-visits, our telehealth visits, these are all components of telehealth services in general. One of the other monstrously confusing issues was, first of all, before we could bill as a distance site and get the G2025, all of our services were going under virtual communication services, right? Virtual communication services are not encounters. So prior to the public health emergency, these were only payable, and again, this was a composite. These were payable using the fee-for-service remote evaluation let's see, remote evaluation, I'm going to misuse a word here. I don't want to say that. It's a composite of the remote evaluation non-RHC codes. It was $13.69. It's changed since then, but if we were going to bill a telehealth visit by our provider as a virtual check-in, we're only getting $13, and that doesn't work. So virtual communication services are at least 5 minutes of communication, technology-based or remote evaluation services furnished by an RHC practitioner. It is not related to a previous RHC service or encounter within the last 7 days, and it does not lead to an encounter within the next 24 hours. So we can, I got a duplicate slide here. So I just wanted to emphasize virtual communication is not an encounter. So when everybody's talking about billing encounters under virtual communication, we're like, hey folks, it's not an encounter, it doesn't work. So we're not being paid for these services. One of the rolling updates we got prior to the G2025 coming out, and the dates confused me, was that the payment for G0071 which is our RHC FQHC specific virtual communication code, was changed to, instead of just including G2010 or G2012, also then included our e-visit codes, the 9942X codes. So 99421, 99422, 99423 were all then added to the composite, and that brought G00712 to $24.75. So today we can be paid G0071 for $24.75. Where you say, well, if my telehealth visits, if my G2025 now includes a telephone visit, why would I ever bill a virtual communication service? Well, because it's not only a telephone call, and remember we're time limited, so it's approximately 5 minutes, a very short call. And it can be a telephone call, but it can also be audio video, but it can also be a text or an email. So if we have a very short call, let's say 2 or 3 minutes, and we have a text, we have an email, we have an e-visit, these can all be virtual communication services. Now again, we have a 5-minute timestamp on these, so we have a little contradictory information, but virtual communication, virtual check-in, the top of that says it must be initiated by the patient. The provider can't call the patient. We have some flexibility on that during our public health emergency. CMS has said we can reach out to those patients we know are at risk. We just can't start cold calling patients, right? That's the big issue. Performed by a physician or other qualified healthcare professional, or a nurse practitioner or PA, provided to an established patient that is waived for COVID-19. It's available to all patients effective March 17. Not originating from an E&M service within the previous 7 days. Does not lead to an E&M service within the next 24 hours. Has 5 to 10 minutes of medical discussion. Virtual check-in, so it can be email or text. So that's where these fit in. Or a very brief telephone call with the provider that a full visit didn't take place. That's what a virtual check-in looks like. RHCs and FQHCs only. We will not bill a G2010 or 2012. Encompasses remote check-in and remote evaluation. It does not include remote monitoring. That's the language I was looking for. I put at $25. There will be co-insurance and deductible. This includes our e-visits. We don't get to bill our e-visits or the G2061 codes. Our e-visits are part of our G0071 at this point and have to be billed as a G0071. Includes patient portal visits, online digital evaluation and management service, up to 7 days cumulative time during 7 days. So you see we've got 5 to 10 minutes, 11 to 20, 21 or more. So again, we need to start and stop time those if we've got a duration indicated. I'm getting repetitive here just because sometimes it takes more than once. We're never going to use any of those codes at the bottom of the screen, RHC or FQHC. We're always going to use G0071. All of our commercial payers have their own payment mechanisms. They pretty closely follow Medicare fee-for-service billing guidelines, but you're going to have to check with each of them. And there's some kind of set structures that they're doing, but definitely they're all different. So there's not one set rule that I can give right now. I think in the midst of our public health emergency, many of us were confused about where care management services fit in, or have they changed during the public health emergency? Excuse me, my throat is getting very dry. Remember, our care management services include 20 minutes of clinical activity towards a care plan per month. We're going to go through some of that. Nothing has changed for care management services. So think about those virtual check-ins. Do you have patients that you're doing a bunch of virtual check-ins on? It's $25.71 for a virtual check-in. Could some of your patients be care management patients? Could you implement a care management service program? Could you do that during the emergency? Do you ever have to see a care management patient face-to-face? Yes, once within the last year. But it includes all of our clinical care activities: telephone, face-to-face, referrals, arranging COVID testing. I think there is a strong place for our care management services that we've kind of overlooked in our public health emergency here. So remember, none of this has changed. We have to have a comprehensive exam. We have to have a visit within the last year. And if we've had a visit within the last year, we don't need an initiating visit. It can be an E&M service. It can be a welcome to Medicare visit. It can be an annual wellness visit. It can be a visit furnished by a doc, nurse practitioner, or PA, or CNM, certified nurse midwife. As long as we've had a visit within the last year, we're good. 20 minutes of care coordination services have been furnished in the calendar month under the direction of the RHC or FQHC physician, PA, nurse practitioner, CNM, and by, look at this, RHC, FQHC practitioner, or clinical personnel under general supervision. So we get all of our nursing services included under care management services, again, referral coordination, etc. Don't miss out on these. Now, here's the other thing we miss out on. We all think care management services, oh, well, we have to have at least 2, usually more. When care management services first came out, most of us said 2 chronic conditions is a healthy patient for us, but different question. 2 or more chronic conditions expected to last at least 12 months or until the death of the patient and place the patient at significant risk of death, exacerbation, decompensation, functional decline, or look at option B. Any behavioral health or psychiatric condition being treated by our RHC or FQHC provider, including substance abuse, that in the clinical judgment of our provider warrants behavioral health intervention. Look at that, including substance abuse disorders. So in my view, we have this other option for a care management service that is very interesting and very timely. What are the service requirements for option B? Option B, we have to have assessment and follow-up monitoring using validated scales. We have to have a behavioral health care plan, so we have a behavioral health care team, and we can revise care plans for patients who are not progressing, facilitating coordinating treatment counts, and continuity of care with a designated team member. We have our service requirements. Remember, we have to have structured data and a certified EHR. We have to have 24/7 access to a physician or other qualified healthcare professional. That does not mean our providers have to be on the phone 24/7. It means somebody has to pick up the phone after hours and have access to our providers. This is the big one. We have to have comprehensive care management, including systematic assessment of the patient, as well as a comprehensive care plan. That's the big one. We have to have a care plan, and all of the 20 minutes per patient per month, and all of our care activity is to address the care plan. That's the whole point. If we have a care plan, though, we're managing care transitions, we're coordinating with other resources, and we are offering enhanced opportunities to communicate with us, not just on the telephone, but via our portal, text messages, etc. All of these we make available to our patient. The huge thing for care management service beneficiary consent. We have to let the patient know there's going to be a co-insurance. There is cost sharing with this. We have to let them know what it is, and we have to document that we've informed them we have their consent to enter into a care management service. You can be the only provider with a care management service with the patient. If they go to another provider that month, then you're not going to get it. And they can consult with specialists under this service. Again, we have to have that initiating visit. We also have this G0512, which is a psychiatric care management services. And on the psychiatric care management service, we got 70 minutes in the first month and 60 minutes in each subsequent month. And these are under the direction of our RHC provider, but we also have an RHC practitioner or behavioral healthcare manager under general supervision that is interacting with us for our care management services. The care management service for, oh, did I miss a slide? I think back on G0511, I thought I had a payment amount in here. Not sure what happened to it. Sorry about that. Sorry to flip my slides here. Let's get back here. Come right back here. The 2020 rate for coordination of care management or care management services, the G0512 is $141. The G0511, that's what I was missing, is $66.77 this year. So 20 minutes of care coordination per month. Whenever I ask people how long does it take to get their 20 minutes, they always say it usually takes one touch. One referral coordination, coordinating one referral for a patient usually gets that 20 minutes per month. In my view, and yeah, we were talking time here spent on the phone, but I think a lot of us are already doing these minus a formalized care plan. But this is where care management fits in with our telehealth services. They're still here. We could be doing a lot of our, if we had a care plan, a lot of what would be virtual check-ins as care management time. So as we're going through these telehealth services, and again, remember, we only have to have an initiating visit of having seen that patient once in the last year. Otherwise, there's no face-to-face requirement for any of this. There's the eligibility team. I'll let you all review those on your own. We have to have a behavioral healthcare manager that coordinates with us in our care management service for G0512. The psychiatric consultant participates in regular reviews with our provider staff. And these are our coordination of care billing providers. So all of these providers can bill, but again, our nursing staff, anybody that's licensed clinical staff can bill these services. It's clinical professionals only. So services performed directly by physician or non-physician practitioner or clinical staff count towards a minimum amount of service time. I can't speak today, I'm getting all tongue-tied. Time spent by administrative or clerical staff does not count. So virtual check-in can easily be integrated into a care management service under the right circumstances. And really the main thing that's missing from that is the care plan and beneficiary consent. So that's what that, oh, there's my slide all the way at the end. And I'm undercharging that. I didn't update my charge amount. But G0511 or G0512, they can be billed alone or with another encounter on the claim. Once per month per beneficiary, cannot be billed if somebody else has the service for that month. Again, G0511, G0512 are both these composite codes that are set by a national average of the physician fee schedule payment amounts, $66.77 for 2020, and that gets updated annually. So I've got a bunch of reference material in here that I would encourage everyone to go look at, especially in these bulletins and especially in the IHCP FAQs for telehealth or have a lot of good information in those. And of course, there's my contact information. I'm going to go ahead and open up the chat box here. The one question on here, can we get a copy of the PowerPoint presentation? Absolutely. I will be sending that to Dana and Dana will send that out. So we'll give a couple more minutes for questions. I hope that we provided some useful information to you today. I know we're all kind of webinared out, right? And now all of our conferences are turning into virtual conferences, and that's super boring. But it's also a lot safer. I don't have to quarantine after I get home from stuff. But I appreciate your attention on probably a well-worn topic now, but it does help to repeat these things.
Charles, I'm not seeing any more questions in the chat or the Q&A, but Indiana Rural Health would like to thank you very much for joining us today and being able to help on this topic that definitely needs to be retouched on a continuous basis.
Well, thank you everybody very much. And please feel free to contact me or Dana with questions that I can follow up with you on. And otherwise, don't hurt yourself on the 4th of July and have a good holiday. Thanks a lot.